Thank you. So, some of my research, it might be assumed I'd feel some kinship with public health, but also do because I was raised by a public health nurse who would be very proud that I've been asked to come here and speak with you all. I always kind of like to start with a story to kind of illustrate what I'm talking about, and as well sort of answer the question that's on the minds of a lot of people in audiences to whom I speak. Why the heck would you be involved in addiction medicine? Why would you choose to do that? And so, you know, there are lots of stories every day, some of which are heartwarming, some of which are heartbreaking. And so I was thinking a lot about what to share, and perhaps against my better judgment, I chose this one. It was early in my first year of residency training, and I was on call for obstetrics, right? And middle of the night, sleeping as soundly as a first-year family medicine resident can sleep, and the phone rings in my call room, and the labor and delivery nurse says, "Dr. Brown, we need you out on labor and delivery right now." I don't know if there's anything that can wake you up faster than those words coming out of the mouth of a labor and delivery nurse. And so was escorted to the room, and there was a wildly agitated pregnant woman in the bed, it turned out, who was intoxicated on methamphetamine. And as I positioned myself to try to do an exam, I got a foot firmly planted in my chest and went careening back into the biohazard bin on the other side of the room. Sadly, tragically, the infant that was born was a 26-weeker who had a very complicated course in the neonatal intensive care unit and did not survive. Thank you, Dr. Brown. Why would you share that awful story with us? Well, you know, a couple reasons. One, I think it's stories like that where when you're providing care to addicted patients, it can really tax your compassion. And that can be the initial instinct is, geez, why are you doing these stupid things? But then this patient and others in situations where their substance use were putting their health and the health of others endangered, the other thought that I had is, wow, this addiction thing must be a very compelling situation. I wonder what's going on there, which is what prompted me to start getting involved in this field. And in this area in particular, I mean, obstetrics and the continuity relationship during pregnancy and early infancy with that family was really one of the things that drew me to family medicine as opposed to a lot of other things. So substance use, I'll be talking mainly about things other than tobacco and alcohol, of course, because you've certainly had a lot of exposure to those things, but I'll provide some brief information about that just by way of comparison to some illicit substance use issues. Illicit substance use happens in about 5% of pregnancies. In the wider population, this is an enormously common problem. 15 to 20% of Americans will struggle with use of some substance, alcohol or illicit, or prescribed opioids at some point in their lives. And that number is even higher in primary care clinic samples and hospital samples, where it exceeds 30%. And tragically, less than 10% of those individuals in a given year get to appropriate treatment. Lots of potential reasons for that. Not perceiving the need for treatment in the addicted individuals themselves, a healthcare system that isn't completely trained up in or confident in addressing these issues, asking about them and getting people to appropriate care. And then of course there are system issues, right, around access and getting people to the treatment that they need. And the things I'll be going over in quite a bit more detail, some of the adverse outcomes associated with the substance use itself, as well as the environment. And I think that's a really, one of the big take-home messages with this that you'll see as I go through some of the evidence around what drugs cause during pregnancy. It can be pretty difficult to tease apart what's the drug causing and what is the environment in which the drug use is happening causing. And that's where it can get kind of difficult sometimes to tease out what's happening out there in the literature and figure out what's really going on. But I think I can provide some good information there. And I'll be taking that not just through pregnancy and neonatal outcomes, but giving you a little information about what we know about outcomes as children are getting to early elementary school age and what exposure to some of these substances might do. I put up this slide just to clarify that we're talking about a spectrum of use of any of these substances, where in some cases, some level of use may be beneficial, right? So opioids might be, a good example there, and someone that has disabling pain, that may improve their quality of life, maybe their function, though the evidence around that is still questionable. Then we get into the extreme end of the spectrum where that use is compulsive, they've lost control over that use, and that use is continuing despite the fact that it's pretty clear that it's causing harm in some way, be it their social or occupational function, their physical health, their relationships, and things like that. So that's just to clarify, this is what's out there, and substance use doesn't always mean problematic use or addiction, but the threshold for concern is certainly lower during pregnancy, right? So while I want to draw that distinction between substance use and substance dependence or addiction, we think about it a little bit differently during pregnancy than we do in, say, a non-pregnant adult. Clearly, I'll get into that a little more as well. So what do we mean by addiction? So the manual that's used in the field most commonly to get at clinical criteria for a substance use disorder is the Diagnostic and Statistical Manual of Mental Disorders, now in its 5th edition. And as you can see here, there are 11 potential criteria, and an individual with a substance use disorder meets these criteria due to maladaptive use repetitively over the last year. With these first 2 criteria, tolerance and withdrawal, indicating that they have a physical dependence on the substance. So they have tolerance to it. They've started to need to use more to get the same effect, or they get less of an effect with their usual use. And withdrawal, meaning that if they try to quit or dramatically reduce their use, they get the classic sort of withdrawal syndrome. All of these other criteria, as you can see, going through them, are these behavioral indicators of that loss of control over use or compulsive use. So using more than they intend, trying to cut down, but not being able to, sacrificing important activities because of use or recovering from it, craving, and things like that. And so this slide, it's probably getting to be too old to be making this reference anymore, but this is your brain on drugs slide. Okay, some people remember that. And a lot of what we've learned about the addicted brain has only come around within the last 20 years with these functional imaging studies that tell us a lot about how the addicted brain is different from the non-addicted brain. And while it's a fairly complicated matter, there does seem to be this final common pathway called the mesolimbic system that is the primal reptilian part of our brain that motivates us to drink when we're thirsty, to eat when we're hungry, to seek shelter from cold and heat, and procreate. And you can see here what this is showing is normal brain, increased signal intensity here, normal, that being obliterated with regular methamphetamine use. But then with a period of abstinence, 14 months from methamphetamine in this case, you're starting to see some of that recovery. And that's related to behavior as well, right? Because if someone's engaging in compulsive use and their priorities are rather than food, water, shelter, family, alcohol, drugs. Alcohol or drugs have kind of taken over that top spot in their survival hierarchy, and that's why you see them doing these things that we see as frustrating, right? Not attending to their family, not attending to work and other responsibilities and things like that. But it's not a hopeless situation. But as you can see, that recovery takes some time. 28-day stay and you're done ain't gonna do it. Right? This is typically a chronic, relapsing, remitting condition that requires some ongoing monitoring and engagement in relapse prevention. So there was where I just wanted to set the stage so far as what addiction is, because as I'd received feedback about past sessions, I think one of the areas that people were curious to gain some insight into is what substance use may be associated with that leads pregnant women involved in it to miss appointments, have difficulty with it. And the substance use itself has something to do with that. I'll be getting into some other things that'll illustrate further challenges beyond the substance use itself. So the drug and environment effects on the development of fetus in utero, as well as the child after birth. And then I'll get into some of the particular substances of potential abuse and addiction during pregnancy. Touch briefly on screening and assessment when it comes to controlled substances other than alcohol, and in the field, sort of how we think about treatment. And then get a little bit into my perceptions of some of the ethical issues with this stuff during pregnancy. One thing that I think is pretty key that this audience is likely familiar with that I alluded to earlier is when you're looking at literature delving into the effects of drug on a developing infant, this issue of confounding is pretty key because all of these studies are observational in nature. No one has randomized a group of women to do 3 grams of cocaine a week during their pregnancy and another group not, and compared the babies after they were born. So we're left with observational studies where we would like to be able to say that use of X, cannabis, opiates, leads to Y, say low birth weight, preterm labor, preterm delivery. The interpretation of that literature is complicated by this issue of confounding. Maybe there's something that's strongly associated with the use of opiates or cocaine, like mental health issues, or violence in the home, or lower socioeconomic status, or failure to attend to prenatal care visits that's driving this, right? And as I say, I think that's just an issue to keep in mind as I go through some of the data that I've been delving through to prepare for this, where feel free to stop me, by the way, as I go if you have questions about that or anything else that comes up. So where does that leave us with the data that's out there? Well, there are still ways that we can look at a volume of these data to say, well, we feel pretty convinced that there's a causal relationship here. And that includes, was a study well designed, sort of a classic example of this confounding issue in study design that epidemiologists use a lot was an article that was published actually in the New England Journal of Medicine back in 1981, where the assertion was that, well, we did this case control study where we looked at people with pancreatic cancer, people without pancreatic cancer, and the people with pancreatic cancer were heavy coffee drinkers. So coffee causes pancreatic cancer. What might be a confounder there? What would be strongly associated with heavy coffee drinking? Smoking, right? So there's an illustration that needs to be kept in mind. Then there's the issue of biological plausibility. So say with alcohol, for example, heavy alcohol use may be associated with a lot of other things in that maternal environment, but very few of them we think it biologically plausible to lead to deficits in cognition and behavior and craniofacial abnormalities, for example. Strength of the association is important. What's the increase in risk? One, the dose effect, that's pretty clearly illustrated in literature with tobacco and alcohol. We know that more is worse, more or less. And then with prospective studies, is there a temporal relationship? Did the exposure precede the outcome? And just have multiple studies replicated the findings that are out there. And so those are just, like I say, things to keep in mind with interpreting some of this. So where does this leave us in terms of drugs, illicit drugs, and other things that we should be keeping in mind in looking at the literature and thinking about how substance use in the environment might affect baby? A lot of this is fairly intuitive that we've talked about a little bit. Alcohol, drug use, particularly when it's heavy, can be associated with all sorts of things that can adversely affect fetal outcomes. Mental health issues, lower maternal educational attainment, and I put this emphasis on prenatal care, and I'll be hammering on that quite a bit, because even in the setting of some active substance use, depending on how problematic it is, one of, I think, the key roles in this situation is making sure they're getting prenatal care. That has a greater impact on outcomes such as fetal birth weight than, for example, cessation of casual cannabis use. So that's critically important. So then a child is born, and then there are all sorts of things in that environment that might affect how they're progressing through childhood, right? How is mother, perhaps father, the baby functioning in delivering care to that child? Are there other exposures in that environment that could adversely affect development? Lead exposure, violence in the home, things like that, that all feed into that developmental competency, function during childhood, and what the adult looks like or adolescent looks like later in life. So it can be a confusing web of things to tease apart. So what do we know about substance use during pregnancy and what the substances themselves might be doing? Well, you've gone over these things, I know, quite a bit, and there's quite a list for both tobacco and alcohol that have been well known for decades. Cannabis. So this was an interesting one to dive into a little more. There's been quite a bit of conflict in the literature about what happens with cannabis exposure. To my read of what's come out, this looks to be where things are landing. There may be some effects on fetal growth. The study where they looked at it and tried to establish some sort of that dose-response relationship is more worse. Found that in the heaviest using quartile in this study, this was the Ottawa prenatal prospective studies, birth weight on average was about 200 grams less. One of the complicating factors in interpreting some of these studies, incidentally, heavy cannabis use is also associated with smoking. So, when they've either controlled for that or eliminated tobacco-using women from these observational studies, this is what they've seen in childhood so far as attainment of milestones at around 36 months. There have been some studies where regular use has been associated with some academic dysfunction early on. Some studies have found that to go away depending on the environment as well. But I haven't found any studies that demonstrated a significant impact on IQ itself. And one study did find that there was an increase in depression among adolescents that were exposed to cannabis in utero and exposed to the environment in which cannabis use was happening. Stimulants. The primary issue here, and the big ones so far as illicit substance use, cocaine, And that's really the main one we see around Madison. Are any of you from areas where you see a lot of methamphetamine use too? Yeah. And do you see, around Madison, the methamphetamine use that I've seen, as opposed to California, I saw a lot of chronic heavy daily use in California. In Madison, I'm seeing mainly binge use. Do you guys see a lot of chronic daily use too? You see a lot of, horrible drug, really awful. So the main issue, or one of them with both of these, is that a stimulant restricts blood flow through the placenta that can lead to any of these complications: placental abruption, preterm labor, preterm delivery, growth restriction. That restriction of blood supply is also thought to potentially lead to some of these GI issues, necrotizing enterocolitis, although that's also associated with preterm labor and preterm delivery. So whether that's cocaine and interrupted blood flow is still not totally well understood. Behavioral issues have been associated, depending on the study, attentional deficits, impulsivity issues. Again, the literature's a little unclear on that. That makes some sense to me from what we see in individuals in adolescence, young adulthood, who are addicted to or expose themselves to cocaine with regularity. That is a crowd where you also see those issues. Difficulty with impulsivity when crime is associated with illicit substance use. With a cocaine use disorder, it's more likely to involve violence, and things like that, than say addiction to cannabis or opioids. Again, a number of studies have asserted that those may be there, but may be ameliorated again by correcting some of the issues in the environment in which that substance use was happening, or the rearing happening in a different environment. We don't have nearly as much data on methamphetamine, but with even the limited data that's out there, the effect sizes on these issues seem to be larger for methamphetamine. Placental syndromes, preterm labor and delivery, low birth weight, fetal death, even more clearly associated, it seems, with methamphetamine than cocaine. And some stronger assertions around some actual developmental issues in early childhood, motor development, and perhaps cognitive impairment into the preschool years. So far as receiving prescription amphetamines, so Adderall, Ritalin, and things like that, in a mother who has been diagnosed with adult attention deficit disorder, takes those during pregnancy, there haven't been effects found with that. Opioids. This is the hot button issue these days, isn't it? Just about everywhere. And it's important to keep in mind how the opioids are being used. And I'll get into this in a little more detail. So there can be the recreational use, perhaps shy of addiction, but where they're using opioids for the high or the euphoria from time to time, the addiction or the substance use disorder. And in this setting, really the situation that creates the greatest risk to fetus is the withdrawal syndrome. That's what's associated with the preterm labor, preterm delivery. So that's really the situation to be aware of and get tackled if it presents you. There are opioids that are used to treat this issue, right? So methadone is the one we know the most about. It's been out there and used for treatment in this setting since 1972 in the United States. It's the regulations around it require that for the addiction indication, it's dispensed out of or supervised by a state and federally licensed treatment facility, of which we have 13 in Wisconsin now. It's a great model, but not accessible to everybody, right? And they tend to be concentrated in more urban areas. Of the approximately 3,400 counties in the United States, not even half of them have a methadone treatment facility in them. So is that? Buprenorphine is a somewhat different animal as opioids go. When we say opioid, so methadone, heroin, morphine, hydrocodone, oxycodone, those are full opioid agonists, right? They go to opioid receptors in the brain, switch them all the way on, which is what causes the euphoria, the other side effects, the most severe being a slowing down of breathing or even stopping of breathing and death or overdose. Buprenorphine is what's called a partial agonist, so it grabs onto those same receptors, but it only turns them on part way, and that's why it's regulated in this setting somewhat differently. With some additional training, a physician can prescribe this like any other controlled substance out of their office. Like I say, it does require some additional training, about 8 hours of online or in-person training, and you need to get a separate DEA number specifically for prescribing those substances. And so far as how things go with those during pregnancy, this is still thought of as first line just because we have more experience with it. Though recent study, I guess about 2 years ago in the New England Journal, where they looked at infants postpartum and found a much lower likelihood of neonatal abstinence and a lower severity with the buprenorphine preparation than with methadone. So that's something to sort of keep on your radar, see if that standard of care changes. And then there's a setting of chronic daily use for pain where, interestingly, the complication rates that I'll be talking about here in a minute seem to be lower than some of these other situations. So far as development, opioids do not appear to be teratogenic in and of themselves. One of the things I mentioned that we get concerned about, watch for, is that neonatal abstinence syndrome, which is pretty difficult to predict. It doesn't seem to have a clear relationship to dose. Lower likelihood, again, with buprenorphine, seems to be lower likelihood with daily use as prescribed for pain. Tends to come on in baby 48 to 72 hours after delivery, though with buprenorphine it can be longer. Can be up to 5 days out. So some hospitals have policies around keeping infant in the hospital for that period of time, as opposed to with other opioids where the period of observation is more typically in that 48 to 72 hour range. And this tends to be what it looks like. So these infants that experience NAS, more difficulty with state regulation, they startle more easily, more irritable, may have more difficulty with feeding, yawning, vomiting, sneezing. And in infants, this doesn't really happen in adults, but infants, newborns can have seizures even with the withdrawal from opioids. What do we know about child development? Again, evidence is a little bit unclear. Some conflicting, some unable to tease apart this issue of potential confounding by the environment. But some associations have been found with behavior, so impulsivity, attentional issues, cognitive development, and a stronger association has been found so far as growth trajectory up to age 3 for infants that were exposed to methadone maintenance in utero. That seems to correct later on in life after that age. Other substances we don't really have a lot of information about. The hallucinogens, entheogens sometimes get lumped in there, so I just put those all together. You don't really the tricky thing with these is it's pretty rare to see heavy daily use and get at that dose effect with these, with pretty rare exception. So we don't really know what kind of impact LSD might have. We don't really know what sort of impact psilocybin might have. With MDMA or ecstasy, there are patterns of heavier use of that out there. And there does seem to be, in those cases, a dose-related impact on 4 and 12-month milestones in those infants. Another substance that looks to be up there with methamphetamine, at least so far as the potential harm to a fetus, are inhalants, so huffing during pregnancy. So the inhalation of solvents, toluene and gasoline probably being the most concerning, that can cause sudden cardiac death in mother, and also has been associated with mental retardation with heavy use, mainly toluene, or inhalation of that solvent. Epidemiologically, you tend to see in the United States this substance use at younger ages. Like the peak tends to be like middle school. And then after that, it's not cool to huff anymore. You're supposed to be drinking alcohol and using opiates. So. And then, of course, an issue to keep in mind is the route of use, because complications can be associated with injection use. They're particularly important to keep in mind because complications in baby can be prevented with appropriate care. HIV being one of the best examples where post-exposure prophylaxis can decrease transmission. And I put this bullet point in there because a lot of times with prenatal care, the routine monitoring for HIV tends to happen earlier if women are appropriately engaged in prenatal care. And then I think from time to time, repeat screening or post-exposure prophylaxis, may fall by the wayside, and it's important in at-risk populations to keep that in mind and not have in your mind, oh, this patient tested HIV negative during her first trimester, so we don't need to worry about it anymore. Hepatitis B, similarly, this is one where the treatment field is in a bit of flux, and where if there's a positive or risk, I tend to get a hepatologist or specialist involved, because there has been some literature indicating that specific treatment, lamivudine, et cetera, may increase transmission, but then it's also been associated with drug resistance in the virus in mom with the regimens that they're using. So it hasn't yet become sort of a definite, we're going to offer everybody this treatment. Hepatitis C, the virus itself doesn't seem to have any effect on OB outcomes. Currently available, most commonly used treatments certainly can, are actually teratogenic ribavirin. Oral agents are coming out there, but cost on the order of $50,000, $60,000 for a month. So there are obvious access issues there. Cutaneous infections, cellulitis, and more severe infections like necrotizing fasciitis, the flesh-eating bacteria that can be very rapidly progressive and life-threatening. And then endocarditis, or when bacteria from the skin are introduced into the bloodstream and seed the heart valve and can cause damage to the heart valve and require prolonged intravenous antibiotics. So prevention is an issue with these, primarily not injecting, right? But there are also harm reduction techniques out there, education around safer practices so far as new needle, clean needle every time. Not sharing works also. Needle sharing itself is pretty much required for HIV transmission. But if somebody even shares, say, spoon in which heroin might be cooked, or the cotton through which it is filtered, can transmit hepatitis C. Of course, it's a much hardier and more infectious virus, which is why harm reduction agencies in the past had talked to folks about using bleach, sterilizing equipment in bleach, which seemed to be effective for transmitting HIV. But unless you're using enough bleach, that it really, really hurts a lot when you inject it, you're probably not eradicating hepatitis C. So I thought I'd touch on some examples of instruments for screening with which you may already be familiar. So I'll probably touch on this fairly briefly. Likely familiar already with some of the instruments for alcohol screening in pregnancy. The American Committee on Obstetrics and Gynecology does recommend universal screening for drug use during pregnancy as well. A lot of these instruments haven't been well studied during pregnancy. So right now, there doesn't seem to be a clearly superior instrument. I simply put up this point to emphasize that just because a screen is positive doesn't mean that there's a diagnosis of addiction. Most of the time in pregnancy, there's probably at least at-risk substance use or intervention that needs to happen though, right? For alcohol, you've heard of the cage before. Not a spectacular instrument to my mind because it's not time sensitive. It's asking about these things over the lifetime. But it has been studied in such a way that drinking and drug use are combined. So just reframing those questions, have you tried to cut down on your drinking or drug use, or have you been annoyed when confronted about your drinking or drug use? And so this is a instrument I put up because it's fairly simple to remember and it may provide some information. Other things that are out there, the assist, is this one that some have seen before? This is one that can be done on a computer and generates a score that asks about tobacco, alcohol, as well as illicit substance use. And so it's nice in that it goes into a fair amount of detail, not just about the quantity and frequency of use, but also the consequences associated with that use. So it gives you more information than some other things, but it's a fairly blunt tool in that a score less than 3 is low risk, a score greater than 27 is high risk. And so you've got this 3 to 27 range that, well, what do we do with that? That's fairly heterogeneous, but clearly warrants further assessment. And then the other two that I have up here that are particular to pregnancy, are these familiar to some? The 4 Ps came out fairly recently, validated within the last 5 years, where ask about parents or family history of substance use, history in a partner. Has the patient herself ever used beer, wine, or liquor? And then quantifying cigarettes, number of drinks daily in the month before pregnancy. So you'll notice there aren't any questions there. They're asking specifically about drug use. So this, though, gets at some of the risk factors, right, that we know. People who smoke daily, more likely to use other things. People who are connected to or live with a partner who's using are more likely to use, et cetera. This substance use risk profile I like because it's a little more cumbersome, but gets into a lot of the issues that are on that measure, as well as some other things that just make sense so far as there being risk factors for potentially harmful substance use. Can folks see that in the back there or not really? So things like, number one, about cigarettes, questions about alcohol, asking about particular substances, very specifically marijuana, cocaine, tranquilizers, living with someone who uses those things, family history, partner history, and also gets into some things about consequences like tolerance, consequences of use, and some associations that I mentioned before, like domestic violence and things like that we'd be concerned about and should go digging for, particularly in women who are using substances with regularity. And an issue that hasn't been sussed out altogether and that I see very different, strongly worded positions about is, should we be doing routine urine testing? And I think the jury's still out on that to a certain extent. I mean, And the reason I say that in part is that urine testing, the technology has improved, the interpretation has gotten a bit more technical, and there can be the issue of a false positive result and how that gets handled, particularly in a setting where we may be considering reporting, right? So at this point, for those reasons, I haven't seen a professional agency saying we should definitely be doing this on everybody as a screening measure. So if through brief interview or screening, we're concerned about what's happening, now what? Well, the detailed assessment, I'm putting up the categories for that to give you a sense of, in the treatment field, the things that we look at to figure out what level of treatment might this individual need. So how many substances do they use? How long have they been using? If someone was using daily and heavily during adolescence, the likelihood that their use disorder is going to be frequently relapsing and remitting is much higher. It's a lot more difficult to get out of that pattern if it's established earlier in life. Consequences, again, to get at those clinical criteria for a use disorder, and also to get a sense of what life is like outside the substance use. What sorts of treatment have they tried, if they've tried any? What has worked, what hasn't worked? We factor other illnesses into the appropriate setting for the patient, their readiness to change, and what their environment is like, with kind of the best example influencing that position is if it's someone that's homeless, recommending outpatient treatment might not work so well. And these are some of the models that are out there. The most common one, medical management, essentially, meaning follow-up in a medical office, potentially with prescription of pharmacotherapy or medications that may help control craving and reduce use of different substances, brief counseling or brief advice, where evidence is best for at-risk alcohol use, some evidence for reducing cocaine use. And then the specialist treatment modalities, outpatient or residential, and then as working in a federally qualified health center where I interact with individuals that often have trouble getting to these in a timely way, I keep 12-step or peer support models in mind, fairly widespread, with examples you likely know being Alcoholics Anonymous, Narcotics Anonymous, and there being other models out there that are fairly widely distributed. And so getting all that history and thinking about those models, that's how specialists in the field think about how to triage this individual to the level of care that would be appropriate, so far as a very controlled environment, or residential or intensive outpatient or outpatient services, again, based on not just on the substance use itself, but these complicating factors that might make it more difficult for them to, say, adhere to the intensity of treatment in an intensive outpatient setting and things like that. And I better pick it up here. So brief interventions, again, this is mainly, the best effects have been in at-risk alcohol use. Seems to be less effective for individuals that have an actual addiction or substance use disorder, with brief framework for that, and being that if they are thinking about change, working with them on goals and coming up with an agreed upon plan around those goals. But even if they're not willing to commit to change, doing some things to still let them know that you're concerned, that you'd like to readdress this in the future, and trying to keep them engaged, right? Again, prenatal care, keeping them in the system is one of the most important things in this situation. So what's available more specifically for treatment for some of the particular substances? I already mentioned the modalities for opioids, and really medication-assisted treatment is first line. Without it, in someone who's addicted to an opioid, relapse rates within the first year exceed 80%. So to try to white knuckle it through detox and abstain, not only is it highly unlikely to succeed, but that situation puts an individual at increased risks for overdose because their tolerance decreases pretty rapidly. This has been best studied in jail populations where if someone's confined for even 5 days, their risk for death is dramatically increased the 2 weeks after release. The odds ratio is about 129 for that period of time versus any other period of time in their life. So again, opioid agonist therapy, we call it, with either methadone or buprenorphine, with methadone being first line, is the treatment. It's a little trickier with buprenorphine. Because I was describing it a little bit, it's a partial agonist. So it goes to these receptors, it only turns them partway on. So somebody's physically dependent on heroin that has their receptors all the way on, and you give them buprenorphine, they're not gonna like you very much because you're gonna put them into immediate and horrible withdrawal. And so to get it started, somebody needs to be in some withdrawal before you get it going, which is a dodgy situation during pregnancy. So that's one of the reasons that methadone is still first line. And these medications and the treatments associated with them in terms of behavioral treatment have been shown to improve neonatal outcomes so far as birth weight, fetal demise, preterm labor and delivery. As I mentioned, there may be some effect with methadone on growth. There tends to be less in effect, however, if the methadone treatment is initiated earlier in pregnancy. So another treatment so far as medication that's available is naltrexone. And there's also a monthly injectable naltrexone called Vivitrol. Again, that being an opioid antagonist, if someone's physically dependent and you give them that, you put them into immediate and horrible withdrawal. So there's again that issue of pregnancy, trying to get a woman through the withdrawal before you start that. Stimulants, a couple of behavioral therapeutic modalities that seem to have particular impact there. Contingency management, cognitive behavioral. When I get to questions, I can answer some about that without going into gory detail, but there aren't any FDA-approved pharmacotherapies for this, unfortunately. So if I'm seeing a patient with a stimulant use disorder, most of the time, what I'm trying to suss out are some of the mental health issues that may be associated with or running with the stimulant use disorder, trying to treat that. And some of those medications actually have been associated with decreases in use, decreased craving. Wellbutrin would be one example where use of methamphetamine and of cocaine have reduced some, which is a category C in pregnancy. And I've kind of been hammering on this a bit already, just to keep in mind that if there is not just substance use, but particularly addiction or compulsive use, I don't know in 15 years that I've seen someone with that issue that doesn't have something else, right? Some mental health issue, something going on psychosocially that should probably be actively addressed as well. A lot of trauma history, particularly in the opioid addicted young women in methadone treatment facilities. The prevalence of childhood sexual abuse is between 1 in 2 and 1 in 4. It's huge. So definitely if you're seeing an opioid addicted individual, exploring that area is really important. And I probably won't have time for this video, so I'll skip that and maybe get back to it. So the tension becomes, I think, we have two patients. We've got mother, we've got infant, and we need to think about, A, as I've been hammering on, keeping the pregnant woman in prenatal care, doing whatever we can to do that because we know that that is going to have the biggest impact on fetal neonatal outcomes. And the other thing just to point out, you know, as I've gone through this data, is that while the use of illicit substances during pregnancy is pretty highly stigmatized, even demonized, the data is much clearer that legal things do more damage than the illegal things. So there's a little bit of a tension there in terms of what do we report and when. And there's this tension with, if I'm a physician involved in prenatal care, I'm considering threatening reporting about creating an adversarial relationship and negatively affecting the likelihood that the woman will come back and continue in the prenatal care that we know is going to be more likely to result in a healthy baby. And as I mentioned earlier, that has pretty well been demonstrated to have a greater impact on birth weight than ceasing some of the illegal substances, primarily cannabis and cocaine. I put this up. This is something you're probably familiar with, but just to illustrate sort of how I thought about this as a family physician who was regularly involved with these patients. And should also mention, given my work in criminal justice, if I've learned anything, it's that how a statute is applied depends on the lawyer that's reading it, right? So, and I'm not a lawyer, so take whatever I'm saying here with a grain of salt, but the language is somewhat vague about required reporting in this situation, and this is the specific language. We report if there's serious physical harm to the unborn child, risk of serious physical harm caused by habitual lack of self-control of the expectant mother, exhibited to a severe degree. And so how would I use that in my own practice if a woman came to me prenatal care, was clearly actively using substances that were of concern to me? Well, clearly we'd try to get her to the treatment that she needed, and we'd be very clear that a priority is continued engagement in prenatal care. And if positive steps along those lines weren't being made, substance use was interfering with that, that was always what led me to feel like, okay, yeah, I need to be thinking about this now.